From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to our listeners around the world. You're listening to JAMA Dermatology Author Interviews. Thanks for joining us. I'm Dr. Adamson, the web editor for JAMA Dermatology and host of this podcast episode. Total body photography has been utilized by dermatologists for approximately 40 years to enhance melanoma screening efforts. Advances in non-invasive skin imaging technology hold promise for improving melanoma outcomes by enhancing early detection, decreasing benign lesion biopsies, and even reducing cost of care. However, that promise remains theoretical unless the technology is subject to rigorous evaluation, ideally in the form of a clinical trial. In a new study in JAMA Dermatology, authors report the results of a randomized clinical trial of a total body photography device and its effects on number and rates of excisions and biopsies in patients at high risk of melanoma. This paper is also paired with a cost-effectiveness analysis of the outcomes from this randomized clinical trial. And I also had the honor of co-authoring an editorial about these two new manuscripts in JAMA Dermatology. And my co-author and lead author on that editorial is Dr. Laura K. Ferris, who is a professor and chair of dermatology at the University of North Carolina at Chapel Hill. But today we're going to focus on the randomized clinical trial. And it's my pleasure to introduce to you Dr. Monika Janda, who is a professor in the Center for Health Services Research at the University of Queensland in Brisbane, Australia. She's here to discuss her work in this hotly debated topic of melanoma screening. Welcome to the podcast, Dr. Janda.
Thank you so much for having me, Dr. Adamson.
I'm very excited to have you. I've been fond of a lot of your work in the melanoma space over the last many years. And for those of you that might not be as familiar, Dr. Janda, would you mind telling them a little bit about yourself, what you do? I know you're mostly a researcher, not a dermatologist, which some may not know. But you mind just telling us a little bit about yourself and your work?
I'd love to. So my background is in psychology, behavioral science, and I work together with a team of dermatologists and statisticians and health economists on this particular trial.
And you've done, a lot of work in melanoma and other diseases as well. But what made you decide to study this specific topic of total body photography?
So similar to the USA, Australia is a very vast country and we have a lot of regional and rural sites. And so when the 3D total body imaging devices came online, we were very excited about the prospect of the potential for teledermatology. So really bringing our dermatology service out into the regions. So as a health services researcher, we thought it's a fantastic idea to test it. We did a small cohort study to get used to the device, and then we started this randomized trial in 2018. And so the possibility of teledermatology using these new devices was very exciting to us.
Yeah, and this device that you are using employs like 90 cameras or more that take this 3D image from, and you create an avatar, and then you can also have dermoscopy photos associated with the lesions on the avatar. So it's a pretty high-tech device, if I'm not mistaken.
That's correct. And if you think about it from the patient's side of view, it's relatively convenient. So the 92 cameras all come on at once and you don't have to change position. The image taking is quite fast. And then it takes a little while to build the avatar. But then, as you said, the dermoscopy can be then integrated into the avatar. And so there's also some artificial intelligence algorithms embedded that group the lesions by size, color, and irregularity of the edges. And so, when the device came online, we were really very excited. So this particular trial had really three aims. One was to study whether and how it can be integrated into the health services, especially with regards to the teledermatology aspects. The digital technology is something relatively new, I would say, in dermatology. So we wanted to know more about the information technology aspects and digital technology aspects and integration into the IEMR and so on that we needed to learn about. And then obviously we wanted to see whether it was even possible to randomize, because we thought the patients are probably going to be very excited about the technology.
Mm-hmm.
And so we were very pleased when our randomization was feasible and we were able to recruit our participants in good time.
So how exactly was the intervention arm versus the control arm in this trial? I know the patients that were recruited for this trial were at high risk. Either they had a melanoma in the past or had a strong family history or had a genetic predisposition or dysplastic nevus syndrome. So the population where you would see some kind of signal, this is the kind of population that you'd want to recruit. But can you explain to the audience what the control arm was versus the usual care for this population?
Yes, so as you correctly stated, all our participants were very high risk. So they either had a melanoma before the age of 40 or 2 or more melanomas before the age of 65. Or a few of the patients were very high risk because of their dysplastic nevus status. So all of them very high risk and all of them under surveillance by either a dermatologist, or in Australia, a lot of dermatology care is also done in the general practice, family practice, because we have so much burden. And so all of them were under routine surveillance with the usual doctor. And then in the intervention group, we added the 3D total body imaging plus digital dermoscopy in a telehealth setting. So what that means is that the imaging was done in a research setting and junior clinicians were looking after the participants when they came in for their imaging. And then every fortnight, we had one very senior dermatologist working together with the junior clinicians, looking at the digital image and reviewing it, looking for anything that was of concern. And if there was a lesion of concern, then a letter was written to the participant's own doctor to say, hey, on the imaging, we found this lesion. Could you please review it? And if there was any more detail, then that was stated as well. But it was basically a little bit similar maybe to radiology, where the radiologist would say upon reviewing the image, this is what I see. And then it's up to the treating doctor to make the decision on what to do with it.
And were there repeat teledermoscopy image taking, or did that just happen at the baseline visit?
No, in this study, we called our participants back every 6 months, and it was a 2-year study. So they came in 6 monthly over 24 months. And our control group participants, we offered them imaging at the very last time point after they had completed their questionnaires. And one reason was, again, our concern that we might not get a control group accepting, given that probably most of the participants were really interested in the technology.
And so what was your hypothesis going in? What did you think you were going to find by using this technology?
Yes, so just before I get to that point, I just wanted to mention to your listeners that we were not using the artificial intelligence tools that are also already embedded in the device. So this includes the change module, which shows whether something has changed over time based on image analysis. And also we didn't use the score for dermoscopy, which shows the degree of suspicion. We didn't use those because we were not sure whether they were suited for an Australian audience, and we hadn't validated it in Australia at the time. So our hypothesis was that having the imaging would help us to reduce the number of excisions for benign lesions. The reason why that is an important outcome is because the excisions for benign lesions contributes a great amount of the costs for the Australian health system with regards to skin cancer care.
So then this leads me to the results. What did you in fact find? Did the inclusion of this powerful technology actually reduce the amount of benign biopsies and benign excisions and increase the amount of early melanomas that you found, right? Because that should be one of the goals, right? Is being able to be very precise in finding the lesions that potentially matter versus leaving alone the ones that don't.
Yes, so when we looked at the results, we did not find that our hypothesis was confirmed. We found that adding the 3D imaging in this particular teledermatology setting in which we tried it led to more biopsies and excisions for the intervention participants. And we also found that our intervention group had a smaller number of melanomas detected, also that this was not statistically significant. The lower number, when we looked into it a bit more deeply, was likely due to some of our control group participants having multiple melanomas detected. So we had 9 participants in the control group with multiple melanomas during the study, and only 3 in the intervention group with multiple melanomas during the study. What was really interesting to us was that we had a really high burden of malignancies overall. So this included melanomas and also the keratinocyte cancers. So we had a huge number of malignancies detected over the 2-year period in this very high-risk group.
And were there more keratinocyte carcinomas detected in the intervention group?
Yes, there were more keratinocyte carcinomas detected in the intervention group than in the control group.
So basically, what the study showed is that introducing this technology in this setting with these parameters, it did not lead to finding more early melanomas, but it did lead to finding more keratinocyte carcinomas, which for the most part, we don't necessarily actively screen for to reduce mortality. Was that surprising to you?
Yes, that was our finding in this particular setting with the teledermatology review without the additional support by artificial intelligence algorithms. When I looked back at some of your recent podcasts and papers, I remembered the fantastic study by Dr. Elmore, and you had a podcast about that study a few years ago. It was about pathologists and whether having another second opinion changed the pathologist's decision.
Right. Yeah, it changed, or it altered whether they called something malignant or benign, or it changed the category in which they decided based on it being a second opinion versus not.
So maybe having the additional look through the teledermatology pathway that we had might have added some additional lesions that were relevant to obviously remove once we saw them, such as the keratinocyte cancers. And so that might have changed the decision-making maybe of the participants' own doctors when they received the letters from us to say, hey, there's something here. Would you please have a look?
Do you know how often that happened? Did the referring doctors or the doctors that were taking care of these patients, do you know if they every single time decided to take a biopsy, or did they observe some of the lesions? Were you able to know that?
We didn't collect that particular data, so I think that would be something to do probably in our next study to get exact information from our participants' own doctors on how they decided to act once they received our letter.
So as a matter of disclosure, I am the director of a melanoma and pigment and lesion clinic, and I engage in total body photography, 2D, not 3D. And I was very surprised by these results as well. What do you think accounts for them? And do you think this data should inform whether total body photography is useful in this setting or not?
Our study is really useful with regards to showing that it is possible to do a randomized trial in this setting, and that with any technology, that should be our ultimate decision tool to really test it very carefully in this setting. This particular study was sort of done at one point in time when we didn't use the full capabilities of the device. And since then, we have looked more deeply into the artificial intelligence algorithms and how they could be used in clinic and so on. So I think it's really promising with regards to the possibility of doing trials in this setting. And I hope that we can do more in the future. And the next trials probably should be done in more than one research setting. So ours was very much a research setting. And the difference probably to your clinic is that a clinician who used the imaging, which was our teledermatologist, and the clinician who decided on the treatment were two different persons, whereas in your setting, probably when you use it in your clinic, you are the person that then makes the decision based on that device.
That is a correct assumption.
Exactly. And so there was a previous study from our Sydney colleagues that had used it in a similar setting as yours, 2D imaging as well and in a high-risk clinic. And they found that it was actually probably cost-effective and useful. So I think our teledermatology setting, the way how we tested it here, probably contributed to the results. So I don't think this study would be the one to decide on whether or not this is clinically useful, but it's really helpful to understand how to use it in a teledermatology setting in the future.
Yeah, and I think that's probably one of the major contributions of this study is you did it in a randomized fashion. You show that that's possible. That usually in a well-done way is the highest bar we have for evidence. And I think that particularly in the melanoma screening space, we don't necessarily have that kind of data. So I think that this is also important for helping us decide future trials or who to include or not include, or whether we should use AI or not.
Exactly. And that is probably one of the criticisms of many AI algorithms, that often they are introduced without necessarily the highest standard of testing, going all the way to the randomized trials. And so then we have seen a number of occasions where the algorithms in the end did not perform the way that we had expected based on laboratory-based data. And so having a trial in this setting is very important.
Is there anything else about this study that surprised you or you want to mention that caught your attention?
One of the topics that we really thought about a lot from a health services perspective is how now can we use these amazing devices in the teledermatology setting for our regional and rural areas. And one of the things that we have started, now we have a sort of larger cohort study going on. We have now 15 of these devices in different settings, so research settings, but also hospital settings. And what we have found is that we probably need a new health professional. We call them skin imaging technicians or melanographers. And we are currently now training this workforce to conduct that skin imaging in a very systematic way. And this is exciting to have this new type of health professionals coming online and contributing to the care in the future.
Definitely the cutting edge of screening, to be thinking about how we could have a different healthcare professional that would be involved. But it also begs the question about the outcome. Is the outcome of interest more melanoma, or is the outcome of interest, does this help save lives? Because what the study has also shown, the companion study, is that it certainly costs more money for this intervention, at least in the setting in which it was deployed. But the ultimate question, I think that patients worry about the most, is this going to save my life? Does that trial need to be done before this gets deployed, or is that something that is being thought about?
So I think it's a really important question, and one that comes up in a lot of healthcare settings. I think we have a two-pronged problem here. The one is, how do we test less in those people that don't need it? So the low-risk participants, how can we really avoid testing and excising in them? And then we have the high-risk group, and in them we probably are still overlooking some of the most important lesions that we need to excise, and we need to excise them quickly. And so it's necessary to predict who will actually develop those melanomas that will end up killing people. So we have to look at both ends of that curve and do more testing probably for some people that have the risk of developing the thick and lethal melanomas, and less testing in the low risk group. And I think the algorithms will be able to help us to differentiate better between those groups. We're not there yet, but that's what I think we should be working towards.
I think we can both agree there. There's a lot more work to do. But I want to thank you so much, Dr. Janda, for being on the podcast. I am Dr. Adamson, and I've been speaking with Dr. Monika Janda about a new randomized controlled trial of 3D total body photography. You can find a link to the papers, the editorial, and the cost effectiveness study in this episode's description. This episode was produced by Daniel Masisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.